started when the clock hits 9:30, or at least my click hits 9:30, which it has done right now. So, okay, welcome everyone. It is 9:30. I'm Kara Kumari with DIDD. Thank you for joining us for this Wednesday's version of office hours. We do have several questions that were submitted ahead of time, so we will be going through those first. Just a reminder that the chat box is open. Please address your question to everyone. We will go through those once we get through the questions that were submitted ahead of time, and everyone is muted except for our panelists so that we can have a good meeting. I think that's all I've got to start with. So I'm going to turn it over to Commissioner Turner to give us some opening remarks. Commissioner.
Thanks, Kara. Good morning, everyone. I appreciate you joining us again today. Obviously, as Kara mentioned, we've got a lot of questions that are coming in, and there's already, the chat box is already pretty lit as it is. So thank you for submitting those questions. We want to make sure that we get through a lot of those questions, so I'll try to be as brief as I can today. Obviously, a number of things that are happening around COVID and the increases that we're seeing and the impact on our community. We certainly want to make sure we address that. I know Dr. Davis is going to be mentioning a lot of different conversation points that are important for this. And I want to just continue to drive home to everyone that we work with that this thing is still very, very real. And I know the temptation for us, myself included, is to fall victim to the fatigue of it's here and it's going to be here for a while. But I really want to stress that we need to continue to treat it with the same sort of urgency that we did over the summer when we saw some initial spikes in our population and in the homes and inside your organizations, because it's continuing to spike right now. And I think we're trending in a direction that I don't think any of us are comfortable with. And obviously we want to be careful in what we're doing. So as we work through this, Dr. Davis will certainly work his best to give you the answers that you need right now. And if there are some questions that you have that we can't provide the answers to right away from a clinical perspective, we've got a hotline right to the Department of Health. They've been very good with us trying to get us information, and we want to make sure that we get whatever we need to be able to provide to you for you to make some decisions inside your organization. But I do want to continue to stress to everyone that this thing is still very real. And thank you for what you've been doing to protect persons supported. Thank you to your DSPs that have been showing up every day to provide that level of care and engagement for the persons that they're responsible for. And we'll go ahead and get started with the questions on that. Thanks, Kara.
Kara, you're muted.
Gets me every time. All right, a couple of things I did want to mention right before we jump into the questions. First of all, we are in the process of collecting input for the IDD integration and overview document. That document can be found on the IDD integration page. Just so you know, we will be taking comments on that overview until November 13th, which is a month after the Family Focused Forum that we had last week, and of course, with ample time for that last stakeholder presentation that we had at the beginning of October. We would ask you guys to respect that deadline so that we can have time to review all of the feedback and make sure that's incorporated as we move forward. Okay, so with that, we're going to go to the questions we've had submitted before, prior to this. They are very COVID heavy, and the first one is a multiple question. So since managing and reporting of COVID-19 positive cases continues to evolve, please review the details of the information requested of an agency when a positive COVID-19 test is reported to the abuse hotline. In particular, what are the current parameters for reporting staff contacts of a positive staff? Is it all staff who work in the home, only staff who have been in direct contact with the staff who tested positive, and contact over a period of time? So that's the first part of the question. So I'm going to give that to Teresa, and then I'll read the second part of the question, the second bunch of questions in the question. Teresa.
Thank you, Kara. To answer the first part of the question regarding who needs to be reported, it is staff that the positive staff person have come in close contact with. Close contact means within 6 feet for 15 minutes or longer. And when you're looking at timeframes, we go back to 2 days prior to the COVID test being administered. So if you have the test administered on a Tuesday, you get results on Friday. We're going to want to know close contacts going back 2 days before Tuesday. So we would ask from Sunday forward. I think that answers the first part, Kara.
Okay, part two. In regards to home visits by person, supporter, and visitors to the home, previous guidance has been within the last 14 days. On the last calls I've made, the investigator asked about visits and visitors in the past 2 days. What are the current parameters? And this is kind of, I guess, similar to what you just answered, Teresa.
Yeah, Kara, just to repeat that close contact would be, within 6 feet of the positive person for 15 minutes or longer. And again, the time period will be going back from the date the test was administered.
Okay, thank you very much, Teresa. And like I said, we have a very COVID-heavy set of questions that were submitted, which I think is reflective of the fact that obviously it's really becoming very clear that things are going in a different direction these days as far as positive cases. Have agencies reported any problems with testing staff using the P23 test? We did several shipments and are still not successful with the process. Are agencies using the Everlywell satisfied with them? Does anyone know? I'm going to turn this over to Dr. Davis, but I'm also going to encourage folks, since you all know more than we do have the chat box open if anyone would like to share their experiences with the different tests, just so other people can see those shared experiences of the different types of tests that are out there. Dr. Davis.
Yeah, the informal kind of anecdotal feedback that I have had is that people are probably having pretty good success with the Everlywell test. I have heard that people have experienced some problems with the P23 tests. So it may be worth your while to consider switching over to Everlywell. I also would invite agency people out there who've been implementing the test to comment in the chat box to let people know what their experience has been like with one or the other tests, or perhaps if they've been using the P23 test, ways that they have been found to be successful with it. I think the problems have come in with the P23 test sometimes in the rapidity with which the results have been reported, and also perhaps managing their portal for the results. So, but I think people who've actually had that experience can probably speak more directly to that. So if you have an experience that you can report, you can put that in the chat box. Thank you, Kara.
Excellent. Thank you, Dr. Davis. Okay, but I am going to keep Dr. Davis on the phone. Some staff continue to test positive for COVID after multiple tests, although the person continues to test positive with both the self-kits and the test conducted by primary care. The doctor is stating that the person can return to work in the homes. Some staff are presenting with new or elevated medical conditions, but may not be exhibiting symptoms such as fever or coughing. Are COVID-19 positive staff able to continue working in the residential homes, even with a note from the primary care physician? There is a concern about if the COVID positive staff is still shedding the virus and contagious, but has a doctor's note stating they can work. Dr. Davis.
Yeah, so I will mention first of all here that there are two ways to be cleared to work after you have had a positive COVID-19 test. One of those ways is to get a negative test. And so it appears that from this question, the person who's asking the question has had a situation where a person has received a positive test and then has gone back to get another test and found themselves to be positive again. You can often test positive even after you have cleared the other criterion, which is that you have gone 10 days since the date that you got the positive test. And so that 10 days, the last day of that has to be relatively symptom-free. So your symptoms have improved significantly. And with respect to fever in particular, that you must not have had a fever for 24 hours without the aid of any type of fever reducing medication like Tylenol or acetaminophen or anything like that. So those things, that is the criterion, probably the default criterion that I recommend for most people. In a circumstance where somebody is having symptoms, we have recommended that people not work while they're having symptoms. However, I would say that if they have had an evaluation, they've met that 10-day criterion, and they have also had a note from their doctor that says they are no longer contagious, no longer shedding virus, that is a circumstance that I think an agency could have their policy be that with a doctor's note, a person could work under that circumstance. I do want to reflect that there is a mandate that was sent out early in the pandemic by TennCare that stated that if a person's COVID positive, they are not to work. But that means that they're COVID positive and shedding the virus have not met that 10-day criterion that I just described. So I think that answers the question, Kara. If there's a need for any follow-up to that, people can ask that in the chat box. Thank you.
Wonderful. And I see that people are sharing some answers and some feedback in the chat box, so we're happy about that. Is there a plan in place to allow providers to continue routine testing without using the Department of Health offices once Everly is no longer supported as the testing entity of choice by DIDD? Dr. Davis, do you want to answer this question?
So for now, we have planned through the end of 2020. So December 31st, 2020 is the date that we have said, okay, that's when we know that we're going to have access to this testing until then. So the Department of Health has given us that assurance. After that, decisions will have to be made about what the continuing testing program needs to look like. So we've committed up until then. As that date approaches, we'll be making additional decisions and communications with the Department of Health. Thank you, Kara.
Okay, so our next question is actually, Dr. Davis, you might want to answer this, but I can assist if you need to. With the IDD integration overview forms for community providers of clinical service, there are 2 forms listed for each discipline. Will they be the same both times or different? Dr. Davis, you kind of want to explain what we've got going on as far as the clinical forums that we have starting today.
Okay. Yes, absolutely. So we have established forums for behavior analysts and other therapy providers, and we have different dates that we have established for those, and I don't have those dates right handy. So if I know one of them is today at 11 o'clock for therapy providers, so that would include OT, PT, speech and language, nutrition. Any of those disciplines can come to that forum that we're going to hold today. And what we're basically trying to do is to come up with some suggestions for what the model of service may look like going forward. It's already been decided that we are going to use what's called a consultative model of service. But what we need to do is kind of fill in the gaps there and determine exactly what a consultative service model needs to look like to meet the needs of the persons that we support. And so that's what we're going to be trying to gather today through this forum and through the other forums that we're going to be doing for behavior analysts. And I think we may have another one for therapists. So we may have something for nursing that'll look a little bit different. But we want to get this information and try to get as much information as we can to inform us as we start to make decisions about how to fund these services and how to provide these services to the persons we support. Kara?
Thank you very much, Dr. Davis. Okay, next question. Sorry, I was going through just kind of taking a look at what we had. There was mentioned in an office hours in September, there's a group working through pilot project with Jerry Bernard of Charles Lee, setting up staff different than current staffing models. We'll be introducing curriculum and how tech can impact daily lives, helping facilitate tech-based services and plans of people open to and desirous of that. Will you update the progress of this group? Jordan has been quiet so far, but it is his turn to give an update. And we can Jordan, if you can, Harold is currently not a panelist. So Jordan, why don't you start?
Okay, yeah, no problem. So yeah, I think some of you on the call know Jerry Bernard. If you don't, he originally developed a tech program in South Carolina at an organization called the Charles Lee Organization. We secured him over the course of the last year to do some consultation with some of the agencies involved in our tech pilot projects. In short, his area of expertise is about organizational development around tech-first principles for services and some creative ways to develop your staffing in general, staffing patterns, staff knowledge, training, and ability, and then apply that to a tech-first approach across your entire organization. The results for the Charles Lee Organization were and are certainly overwhelming, massively increased independence, levels of independence for people across the entirety of their caseload. Certainly some more creative ways to deploy staffing across the entirety of that caseload that reduces staffing burdens on the agency while obviously supporting people to be as independent as they can be. And so they've been actively involved with several agencies over the course of the last couple of months. We're in the process of securing his services again for the upcoming year, and certainly look forward to expanding some of the work that he's done. We have a couple of agencies who have recently visited the Charles Lee Organization in South Carolina, in fact, last week. In their experience, we're hoping to get some testimonials about that. In fact, on a WebEx forum or perhaps even in this office hours call here shortly. So we do plan on keeping Jerry around for at least another year. Certainly he has, and the agencies with whom he's been consulting have produced the results that we were hoping to see, and we hope to be able to spread that information through the rest of the network shortly.
We did add Harold as a panelist, so if Harold, do you have anything else you would like to add to that? And Harold Sloves is our Director of Innovation, if you are unaware of who he is.
Yes, thank you, Kara and Jordan as well. A couple of things. Jerry Bernard and Charles Lee really were early mentors for us, and really inspired us as to what is possible, and opened our eyes to, at that time anyway, it was certainly the most person-centered program I'd ever seen, by virtue of the unique complementary relationships between technology and DSPs. So we have stuck with Jerry. So what's important for me to note for today is that Jerry and his team transformed the Charles Lee Organization in South Carolina, so expanded into North Carolina. And the difference there is he began with this approach, that technology was an underpinning of what he did. So he has the experience and expertise to say he has both done transformation, but he's also started up an organization using technology. And I think that kind of experience and expertise is going to continue to be vitally important to us in Tennessee. Jerry's very careful to say not everybody wants to move toward this new approach of intermittent supports and the new role for DSPs. And he said, there's a place in our organization for everybody. So there are some folks who may be working a traditional shift. That is clearly over time becoming less prevalent there. But I think it's important for everyone to know that transformation is a process. Not everybody's going to get on that train, but indeed, as the train continues to move, an organization becomes fully embraced with technology. We're just very excited we have this opportunity with Jerry, and that we've had providers go out there to see it. Seeing is believing. It is incredibly impactful. All right, thank you.
Thank you very much, Harold, for that explanation. That was very good. Okay, moving on through the questions. I see we've got one. Any updates on the progress of QA surveys? We do have Pat Nichols on with us, and Pat can give an update.
Yes, good morning, everyone. Thank you, Kara. We are continuing in each region to conduct what we have labeled quality assurance adjusted reviews. These are being done in a desk review format, and if you all have been involved in those surveys, you know that you've had contact with the regional QA units about the scheduling and the timing of submitting information for those. Recently, as we mentioned in open line a couple of weeks ago, we have also begun to conduct some of our staff qualifications and training audits, and those are going on now. We contact every agency and are soliciting information from each agency about what is the best format for them to use to conduct the survey. And so we are continuing to work through and try to meet our goal of conducting reviews for all providers by the end of December. If you have specific questions regarding your survey, I would ask that you contact the appropriate regional QA administrator and just check that out with him or her. Thank you, Kara.
All right, okay. In the unification document, page 21, it says different software is being explored. What current electronic systems are being explored in regards to the unification process for billing and any other data collection? We are spreading the love amongst the executive team today and as far as questions go, because I'm going to give this one to Andy Kidd.
Hey, good morning, everybody, and thanks, Kara. Sorry about that. I was on double mute. Good morning, everybody. So we are currently looking at Therap Services, which is an online platform that covers a lot of the IDD billing and all the processes that go on with IDD. So we're currently looking at that program. However, we haven't made a decision yet. One of the things that we definitely want to do is bring in providers to get feedback on that. And so here in the next couple of weeks, we're going to set up a demo so that you all can take a look at that and give us some feedback. Thanks, Kara.
Wonderful, I appreciate it. Okay, I see that Michelle Bagby did put the dates for all of the different clinical services forums on there, so those are in chat. The next question we've got is with the end of the year being about 9 weeks away, when will a decision be made about in-home day? Our revenues continue to decline and overtime expenses continue to increase. I'm going to bring this one back over to Jordan.
Yeah, thanks, Kara, and thanks for the question, Bill. I think that just as we've done throughout the onset and then continuation of the pandemic, those decisions will continue to be made closer to the time of the current expiration. You know, a really good example of that is 2 weeks ago, the trending relative to rate of positivity and total number of cases certainly appeared to be stabilizing and was moving in the right direction. And then we find ourselves this morning in the opposite perspective with numbers going up and rate of positivity now increasing fairly dramatically across the state. So the last thing we want to do is make any definitive decision far out, because we know now how quickly things can change with this virus. I would say two things. The first of which, as has been true since the beginning, we will continue to assure that people are able to make choices that make sense for them, choices hopefully in an informed environment, respective of their local conditions. We encourage folks to continue to utilize the risk-benefit tool that we provided, which hopefully helps guide circles of support through that decision-making process. And then the other point I'd like to make is that we are not, nor have we ever, prohibiting utilization of community integrated supports, community participation, or employment. So we're offering the homebound service for people that are making that choice to remain socially isolated or distanced to some extent, while also allowing folks the opportunity to engage in more traditional integrated services where both they want to do so and it's safe to do so. So as we get closer to the expiration, which does run through the end of this year, certainly we will communicate any decisions that are made relative to the continuation of that.
Okay, thank you very much, Jordan. Let's see, make sure that I've got the right next question next. Okay, if staff test out on the med admin class and fails, has the rule changed if they can continue administering meds since there are such limited classes until 6/21? We were trying not to wait to send everyone that needs to be recertified, but many staff prefer taking the full class. Teresa, do you want to weigh in on this? And also, Teresa, while I've got you on here, if you want to address the background check thing at this period of time as well, could you do so?
Sure, Kara. In regards to the medication administration, med admin certifications have been extended through June 30th. If there are questions about classes or when they'll be offered, I'm going to defer to Dr. Davis. I just wanted to comment that they were extended by the authority we were previously given under the executive order. We went on and just extended that through the end of the fiscal year. In regards to the background checks, I just wanted to give everyone a quick reminder that when the executive order expired, we sent out notification that meant the background checks needed to be sent or requested within 90 days of that expiration, not meaning that providers, any background checks you had not done during the time the executive order was in effect, you needed to send to either private investigation company or the TBI within that 90-day period for them to run the background checks. So that clock is ticking, and I just wanted to give everyone that gentle reminder that if you have not already sent in those background checks that have not been completed, to please do so. And again, if they come back with something that could be potentially a conviction that would prohibit the person from being hired, please submit that for an exemption request if that's what you choose to do, and we'll get the answer back to you. Thanks, Kara.
Okay, if you didn't see in the chat, somebody asked about Jerry's organization in South Carolina. It is Charles Lee in Spartanburg, South Carolina. Given that many TN IDD providers have invested heavily over many years in EHR systems that have strong interface capabilities, what is being done to ensure partnership with community provider agencies regarding the need to interface? For example, the SANDATA response to interfacing with other EHRs. The provider community hopes that this dynamic is not repeated in DIDD's unification plan. Jordan, you want to talk?
Sure. So pretty simply, or to respond in short, the premise of unification at a root level is efficiency. And so obviously, any system or design efforts that ultimately end up being developed and then deployed relative to unification, be that a single point of billing or as indicated in your question, Luke, around the EVV systems, a primary component of consideration will be efficiency, and certainly interface is a big portion of that discussion. We're not at that point yet. At the point at which we do have solid details relative to any proposed or aligned single systems of billing or other, then certainly we'll take that stuff into consideration. The goal with the unification plan overall is to do everything we can to make the provider experience less administratively burdensome, with the pure intent of allowing agencies to refocus those administrative levels, mid-level management, and their efforts in general on providing quality outcomes for the people that they serve. And so that premise permeates every conversation today and will continue to permeate those conversations going forward as we get into those levels of development.
All right, thank you, Jordan. Going back up to see, we were under the impression that all in-person DIDD audits, inspections, et cetera, were being done virtually, electronically. Has anything changed with this where some in-person visits are beginning to resume? First of all, any changes we're making, we are communicating those in Open Line. So if you're not reading Open Line every Friday, you should be. And also, I'm going to turn it over to Pat Nichols to maybe talk a little bit about it from their point of view and perspective.
Sure. Thank you, Kara. I'm not sure if Amanda, if you are referencing the quality assurance, staff qualifications and training audits that we conduct. We have been in contact with each agency as they come up for review, and we are discussing with them the most appropriate way to conduct these reviews from the provider perspective. That has been in a number of cases where the provider has said, we would like for you to come to our agency to conduct this review, because it does mean if these are done electronically, it does mean that there is a lot of work on the part of the provider to submit us information. Okay, that said, this does not involve any home visiting, any contact with people supported. This is merely one or two of our surveyors coming to the provider agency's administrative office and conducting a review where we socially distance, wear a mask, all of those things. So if that is what you're speaking of, that's what we're trying to do in QA. Thank you, Kara.
Thank you, Pat. With DIDD looking at TheraP, will providers be required to use it? Jordan, do you want to weigh in on this?
Yeah, as indicated in my previous response, what we're doing at this point is surveying any and every potential or available option. If the goal is to try to provide a system, a unified system across all of HCBS that eliminates redundancies for providers in areas of billing, that increases efficiency across the board, that provides a uniform electronic interface, then nothing is off the table. One of the best things, or one of the biggest advantages that we have as an entire community at this point is the consideration of any and every available option to streamline the system. Again, the overarching goal, not just in system development or system selection, in policy development and review of regulatory environments, in each aspect of programming and then licensure or regulatory interface, the goal is to streamline and to reduce redundancies and to increase efficiency. So if and when TheraP is one of the companies that provides a product that has potential to be able to help us streamline across the system, it's so far too early to assume that any decision has or will be made relative to TheraP or any other specific, whether or not we're going to design something internally and implement that or go with a platform that's already available. But at the point at which we get to those decisions, certainly it will be with provider input and with provider knowledge. So, you know, as Commissioner often indicates on this phone call, what's really important for us as a group right now is to be able to have these conversations and ask these questions, but we need to be very careful about information that we receive and assuming that information is legitimate, valid, or a complete truth. And I think that's why we keep these forums going every Wednesday to help weed that stuff out.
Thanks, Jordan. The next question is for Dr. Davis. We are hearing about more rapid tests being sent to the state of Tennessee. Is it possible that DIDD could gain access to some of those tests for provider use? Bruce, do you have any insight into this? I know you are constantly in contact with the Department of Health.
Yes, I have been in touch with the Tennessee Department of Health regarding rapid tests, and we have discussed the possibility of using those within the IDD systems in general. And the difficulty with this at this point is that you have to be what's called a CLIA approved site to be able to do the laboratory test on this. So when you collect a sample via the rapid test, it has to be processed within an hour. And so you have to have this CLIA approved laboratory to be able to do that. And so it has made it difficult to see most agencies with within the IDD system being able to do that. And by the way, I'm using that acronym CLIA. It stands for Clinical Laboratory Improvement Amendments. So this is basically something that you apply for when you want to improve upon a laboratory that you're currently operating to do a new service. And so this new service under this circumstance would be to provide these rapid point of care tests that are offered. So we've thought that that may not be practical for most of our settings. I wouldn't rule it out for all of our settings, and we are certainly looking into this on an ongoing basis to see if we can get this. We are also hopeful that at some point in the near future, there may be a self-rapid test, essentially one that you can do that would almost be like a pregnancy test or something else where you get the results immediately. We're hopeful that something like that may be developed in the relatively near future. So that's the status as it stands right now. I remain in contact with Department of Health, remain vigilant about developments with respect to rapid tests, and we'll provide that information as it becomes available. Kara.
Okay, thank you very much. Next question. This is a question, but it seems to also be a statement at the same time. So has DIDD spoken with other software systems currently in use regarding IDD needs in Tennessee? And that open communication with providers is critical because the implications are huge. Jordan, do you have any thoughts on this? I'll turn it over to you.
I'm sorry, Kara, can you please repeat the question?
I think the question here is has DIDD spoken with any other software systems currently in use about the opportunities to meet the IDD needs?
We're just, again, we're in the very initial stages of reviewing platforms being utilized by other states across the country. And so have we made soft outreach to several? The answer to that question is yes. Have any definitive or have we provided a deeper level of inspection to any one specifically? The answer to that question is no.
Okay, next question. Sorry, I'm trying to get an idea of how much time we have for questions. Is there any progress of establishing the behavioral health crisis teams? Dr. Davis, can you answer this?
There's progress. It's been low, I will have to concede, but we are continuing to work with the Department of Human Resources within the state to establish the positions for that. We're going to have 26 positions across the state. So that work is ongoing. We have also contracted, or we're in the process of contracting with the START Center, which is a START Center out of University of New Hampshire, who is going to be providing a lot of the training for our assessment and stabilization facilitators and assessment and stabilization managers in the program. So yes, that work is ongoing. I cannot provide a time frame right now for how long it is going to take for us to be able to get those in place. And part of that is the unpredictability of whether or not we'll be able to get the positions approved and to get them posted and to get people hired within them. I do want to say that we are working as diligently as we can to get those going because we know how important this piece of what we do is. We know that we have people with intellectual and developmental disabilities who experience co-occurring mental health disorders, and that we need to ensure that they get the appropriate assessment and treatment that they need. So that's why we came up with this idea to have these teams, and that's why we're working diligently now to continue to try to get them developed and get them in place. So that's where we are right now, and I will continue to keep people updated as it relates to our progress, Kara.
Okay, thanks a lot. Dr. Davis, I'm giving the last question we have time for to you as well. Are agencies who have CLIA waiver certifications allowed to do the rapid test?
Well, so if you have a CLIA waiver accreditation, then I think what you can do is apply to have that service added to be able to do the rapid tests added. I can quickly just show you. I was just looking at the application for that. Let's see if I know how to share my screen. Doesn't look like it's going to allow me to share content. Well, that's okay. We can put this out at a different time, but there's an application that has to be completed. Actually, if you are an agency that is CLIA certified currently, I'd like to hear from you, because if we can find out more about how this process is carried out, then maybe we can export that to other agencies that are out there who may have the resources to be able to do that. So yes, I'll be happy to share that information that we have about how to apply, and kind of work with you through the process so that we can export that to others. Carol.
Great. And with that, I'm going to say that we have pretty much reached time. We've had a very active and good discussion today. First of all, thank you to everyone who shared their experiences with the different tests. I hope you all find that helpful, because this is as much your forum as it is our forum. So where you all can share information amongst providers, we certainly want to encourage that during these unprecedented times. So with that, I'm going to turn it over to Commissioner Turner to say final couple of closing words. And
Kara, before you do that, can I just say one more thing? I wanted to mention the vaccination stakeholder group that I'm currently on. The reason I mention this is because the state is actively planning for implementation of vaccinations when they become available. And so later today, the governor is going to be releasing a plan for those for that. And I have been a part of a stakeholder group that has been developing that plan. And I can assure you, I don't want to get real specific with it at this point, but people with intellectual and developmental disabilities are going to be high up on the priority list with respect to vaccinations when they become available. One of the big things that we're going to have to work on as a system is our public information regarding vaccinations. Anytime there is a new vaccination that comes out, there's always a need for a public information campaign. We're going to need the assistance of every agency in speaking consistently about these vaccinations so that we can persuade people to do them, because we're not going to accept something unless it's safe. Let me say that from the outset, that this stakeholder group, the state, the Department of Health is very committed to ensuring that whatever we put out there is safe for people to use. So when we get that assurance that these are safe vaccinations, we will really need to work with our conservators, with our person-supported, and within your agencies to ensure that people get that vaccination. So I just want you to know that the state is working on that, and that you should see from the governor's office this plan coming out later today. Kara.
Very much, Dr. Davis. And I thought we were done, but we have actually had a couple of things come up. First of all, when it comes to in-person visits, like I mentioned, you should be looking at open line, but two other areas where in-person visits have resumed, or three rather, is housing inspections have resumed. Our investigators, when it is necessary in urgent situations, are going out to conduct those investigations. And also some licensure has also resumed as well. So please look at Open Line. That will be the latest information. When we are resuming an in-person, a process in person, we will be notifying everyone in the community of those changes. And we will also try to update our IDD integration page, wrong page, the COVID-19 page, to reflect the newest information in regards to what is being conducted virtually, what is being conducted in person. So, so please utilize those resources. The other thing that I think we needed to mention is that some contradictory information was put in our chat. And so Teresa, regarding medication administration, I'm going to turn it back over to Teresa to give the correct information. Teresa.
Thank you, Kara. I just wanted to clarify and just kind of reiterate what I said before. All medications certifications have been extended through June 30th, meaning everyone's medication administration certificate is valid until that date. If someone takes a test out and fails, that does not negate the fact that their certification is still valid through June 30th. They will need to pass a certification before June 30th to have it extend past that date, meaning beyond June 30th into July and going forward. But failing a pass out now does not negate the fact that their certification is valid until that June 30th date. I just don't want people misunderstanding that or rushing out there having people who test out and fail thinking they need to get them into a class. No, these people are just taking their tests out now earlier than they would need to, because again, that lasts through June 30th. Also, I did want to also state, Kara, really quickly that the remote assistance is still an option out there for folks. So if somebody has taken that course on Relias and there's someone who is medication certified that can remotely assist someone in giving medications to a person supported, that is still a viable option. Well, providers may be waiting for those classes to resume and to have more opportunities. Thank you, Kara.
All right, thanks a lot, Teresa. Okay, we have gone even past our 10:15 mark. So, Commissioner, if you have any quick remarks, we will close this edition of Office Hours.
Yeah, thanks, Kara. No, I'll just be very brief. Again, it was certainly robust today, and that's the whole reason we do this, is for you to have an opportunity and a forum to present your questions and concerns and feedback to us. So thank you for doing that. Please continue to do that as we have these every week. Submit questions in the chat box and in the email forum or email option to get into the forum, and we will certainly make sure that we try to answer those questions. But again, thank you to everyone that's participated today, and we'll look forward to talking to you next week. Carol.
All right, and like always, we will be here next week to answer your questions. So we hope you'll join us then. See y'all later. Bye.